very much to be here, and I'll be here listen your interesting talk.
Muy buenas tardes a todos alumnos. Es para nosotros un honor presentar a nuestro siguiente panelista. Hoy nos acompaña el doctor Jürgen Roskrock. Él es profesor de medicina y director de la clínica ambulatoria de VIH de la Universidad de Bonn en Alemania. Él obtuvo el título de doctor en medicina en la Universidad Rheinstedt de Bonn y completó su residencia en el Departamento de Medicina también de la Universidad de Bonn, y su departamento actualmente trata la corte más grande del mundo de hemofílicos infectados con VIH. Es para nosotros un gran placer poder contar con él. Y doctor, sea por favor bienvenido y muchas gracias por haber aceptado nuestra invitación. Adelante.
Buenas tardes. It's really a great pleasure to be here today and to share some of my experience with the new long-acting formulation of Cabotegravir and Rilpivirina. Let me share my slides. Oops, hang on. So what I want to talk about today is this new combination of long-acting drugs and what opportunities it brings for HIV-suppressed patients. Let me start with my conflict of interest, which you see listed here, and then really start with a already 4-year-old study which was presented at CROI and really was a questionnaire which was given to patients in South Carolina. And the question was, who wants to switch? So how is your interest in potential new antiviral therapies? And remember, in 2018, most individuals living with HIV were on a fixed dose combination, so 1 tablet per day. And you can see that if they were asked, what about a single pill taken once a week, you can see that there were at least 66% who were very interested in that kind of solution. 2 shots given in the clinic every other month, which would be the Cabotegravir formulation. You can see in green, very interested, 38%, somewhat interested, 14%. So you would at least think that half of the individuals asked have interest from moving away from a once daily therapy to something different, which has a different mode of application. Even 2 small plastic implants in the forearm every 6 months, was met as what it was recognized as very interested in 18%. So clearly there is appetite among people living with HIV to explore new modes of delivery. There also more recently has been a study which was conducted in 25 countries, also includes 63 participants from Mexico, to sort of address issues around the increased flexibility of ART delivery, why that may be needed to meet the diverse needs of people living with HIV. And clearly, one of the things we shouldn't forget is that people living with HIV continue to face physical, emotional, and psychosocial challenges with daily therapy. So clearly, stigma is something which is very unique for HIV and has an impact on therapy. And these challenges can include low treatment satisfaction, can lead to virological failure, self-rated overall health being suboptimal, and poor adherence. And if you ask people living with HIV, what are the challenges? Well, then you can see that almost 40% say they worry that taking HIV medicine every day increases the chance of revealing HIV status. And I can tell you from my clinic that indeed, particularly in discordant couples, where one person has HIV, but the other one doesn't know, or the person has not yet disclosed to his partner that she or he is HIV positive, they're afraid of having to hide their medication that someone will discover. Taking HIV pills every day creates bad memories. It's a daily reminder of HIV. Prescription HIV medication limits day-to-day life. And then there's anxiety about the daily dosing schedule. And then there's also a group which says they just simply have difficulty swallowing pills. So you can see that this, on average, is something between 28% and 58%. So still affects a very large proportion of patients who say, you know, if there would be a little bit of flexibility in how we deliver HIV treatment, that would be appreciated. The clinical challenge in daily oral ART here were rated as 10%, swallowing difficulties, malabsorption 10%, gastrointestinal complaints, which may impact oral intake, CNS disease, which make it difficult to adhere to daily medication, and then the increasing amount of drug-drug interactions, particularly in aging patient populations. So which patients eventually could benefit from a long-acting therapy? On the one hand, clearly those with medical reasons, so clearly if you have swallowing difficulties or you have a PEG, patients with co-medications and drug interactions or high pill intake would obviously enjoy different modes of delivery. Patients with malabsorption, renal insufficiency, which precludes the use of certain antivirals, bulimic patients, patients suffering from dementia, long-term pill fatigue, those who have adherence anxiety, and maybe patients on opioid substitution therapy. Central is clearly the fear of stigmatization, so being afraid to disclose your infection status. Patients with different cultural backgrounds, so in particular patients from India or Pakistan, for example, or also from Northern Africa, are much more willing to accept intramuscular injections than oral tablets over time. Very active lifestyle, so frequent travelers, frequently changing working hours can also be a challenge with daily oral therapies. So when these new treatment options came up, obviously several patients have asked for it. So I decided to include a case just to illustrate how therapy evolution is and how this becomes a topic between doctor and patient in the setting of an outpatient HIV clinic. So this was a 36-year-old MSM with HIV diagnosed back in 2001. He had symptoms of acute seroconversion, so mononucleosis-like illness, had a relatively high viral load, CD4 counts were still preserved, and he already had 6 bands. So not all bands in the Western blot, but clearly indicative of recent HIV seroconversion. His genotypic resistance test showed no primary mutations, so all treatments were possible. He was a young fellow, no comorbidities, so otherwise all fine. And obviously, at that time, the question was, would you start antiviral therapy at this point? And obviously in 2001, we were still a little bit reluctant and waited because the CD4 count was 744, whereas you know now, international guidelines recommend treatment initiation independent of CD4 count because the large START trial, which was performed by the INTEREST consortium, demonstrated that there is a benefit even if you start at high CD4 counts. So in this patient, because of the high CD4 count and the lack of data suggesting an advantage of early treatment initiation, we waited at that time, and he started finally in 2011, so 10 years later, with the recommended gold standard at that time, which was TDF, FTC, and efavirenz, which later became available as a fixed dose combination. You can see his viral load at that time was already pretty high. His CD4 count has obviously declined over time. After 4 weeks of this combination, his viral load dropped to 981 copies, 3 months later to 280 copies, and then eventually became undetectable and remained undetectable at all continuous lab measurement time points. Now, when integrase inhibitors became available, we switched him in 2015 to TDF, FTC, and dolutegravir because he was reporting increased CNS toxicity, wild dreams, and dizziness. This is something we know can occur under continuous efavirenz-based therapy, and there is a continuous rate of discontinuations because of CNS effects over time. Then when TAF FTC became available in Germany, we switched him from TDF FTC. Obviously, he's getting older, and we wanted to minimize the risk for long-term renal and bone toxicity. When bictegravir TAF FTC became available as a fixed-dose combination in 2018, we switched him to Biktarvy because that would then be finally 1 tablet per day. But after the switch, he developed nausea and a skin rash and wanted to return back to his original regimen. So we switched back to TAF FTC and dolutegravir. And he owns an own post office. So he's in charge of a post office and is very stressed at work, has a lot to do, and has always been relatively sensitive from his stomach and complains of intermittent gastric pain. He receives pantoprazole, a PPI, co-medication. But he really remained sensitive, and really, once he's heard that there are potentially long-acting therapies becoming available, he said he would really rather receive an injectable and take no tablets any longer. In 2020, he has a longer diarrhea episode after an antibiotic treatment, after a dental procedure where he received clindamycin, and you know that clindamycin very often leads to antibiotic-induced diarrhea. So he really remains very sensitive and has complaints around his gastrointestinal tract, and his wish for non-oral therapy is very strong. So obviously the question then becomes for us, what treatment option would we consider? We could also think of simplifying treatment to just 3-TC dolutegravir, hoping that less drugs lead to better tolerability. We could also try to switch drug classes and change therapy to non-integrase inhibitor-based regimen with doravirine. Or we could really go for the long-acting therapy with cabotegravir and rilpivirine after an initial 4-week oral lead-in, now that that has become available. Or we could switch directly to the long-acting therapy with cabotegravir and rilpivirine and skip the oral lead-in. So because the patient is very afraid of side effects, and since he hasn't been on rilpivirine before, we decided in a discussion with him that we would start with an oral lead-in of 4 weeks, and then on the last day of the oral lead-in would then administer his first intramuscular injections with rilpivirine, which he got into the right gluteus, and then cabotegravir in the left. And that all worked very well. After 4 weeks, he got his second intramuscular injection. The tolerability overall was very good. He says that all his stomach complaints have improved. He feels much better from his gastrointestinal tract. And reassuringly, the viral load remains below 40 copies. The CD4 count is high and comparable to values under previous therapies. So you can see in the further follow-up, he remains undetectable, CD4 count remains stable, and his other lab remains normal. He had a little bit of an elevated LDL cholesterol prior to the switch to the intramuscular therapy, which has not changed very much. So that has remained pretty much the same, showing that this regimen obviously seems to be lipid neutral, as there's no change in comparison to his previous therapy, which was also lipid neutral. Now, what are the particular pharmacological attributes of cabotegravir long-acting? Well, it comes with a very long half-life. It allows the once monthly or every 2-month dosing. There is no dose adjustment required for patient baseline characteristics. There are no food interactions or interactions involving the GI tract. So for someone who has sort of a sensitive GI system, that is obviously attractive. And there is a primary metabolization by UGT1A1 with no CYP3A involvement, a high protein binding. So obviously the risk for drug-drug interactions also is very, very low. Now, cabotegravir and rilpivirine were approved for use in Europe for the following indications. So really for the treatment of HIV infection in adults who are virologically suppressed. I think that's important. So it's not for treatment naive patients, but for individuals who have been on a stable antiviral therapy without present or past evidence of viral resistance to and no prior virological failure with agents of the NNRTI or integrase inhibitor class. Now, in the current label, it also says that prior to the initiation of this combination intramuscular injection therapy, oral cabotegravir together with oral rilpivirine should be taken for 1 month, so for 28 days, to assess tolerability to cabotegravir and rilpivirine, and we'll come to that a little bit. So that tells you that the cabotegravir and rilpivirine are available on the one hand as injectables, but on the other hand also as an oral formulation, which can be used for the lead-in or also for bridging periods. This is the scheme of how cabotegravir rilpivirine long-acting is administered. In our clinic, on average, it is administered every 2 months. But remember, when you start therapy after the oral lead-in, you then start the initiation injection, and you do that for the first 2 months in a 4-week time frame. So the first injection is month 2 after the 28 days of oral lead-in, and then month 3 you have a second injection, and then you start going to the every 2-month injections. Now let me share with you some of the data, because I think it's important to sort of understand where does this regimen fit in and what did the phase 3 studies disclose for information. And obviously there are a lot of studies, and I didn't want to put them all into the time frame I have. So what I'm going to do is I'm going to share a little bit of data from the European patients who participated in the phase 3 study program, and then also some of the recent data which was presented at the CROI conference just 2 weeks ago, which took place virtually. So the main 3 studies which composed the phase 3 study design was the study called FLAIR. This included naive patients. So they went first into induction phase with dolutegravir, bacavir 3-TC for 20 weeks. And when they were undetectable, were then randomized to either stay on their oral therapy or after an oral lead-in, receive 4-weekly injectable therapy. And then ATLAS was suppressed patients for more than 6 months, randomized to continue on their oral therapy or open label for 4 weeks, and then again 4-weekly injections. And then ATLAS 2M was taking suppressed patients, including also ATLAS rollover participants, who were then compared 8-weekly injections to 4-weekly injections, trying to find out whether we get away with less injections. And I think that is very important, because I think one of the big challenges which we have been facing in Europe is, just imagine yourself if you are in a clinic, for example, in London, Chelsea, Westminster. They always say, well, we see our patients every 6 months. We have 4,000 patients in care. Just imagine if you suddenly have to see them every month for an injection. That really does increase a lot of visits. So there is some fear, at least from the treater side, that the system may be overwhelmed if the wish for replacing oral therapies by injectables will be very strong. This is the slide which summarizes the study population for the 3 trials. And you can see this is a sizable number of patients. Now, some of the individuals were rollover patients. So they had prior Cabotegravir long-acting exposure. They were excluded. So overall, there were 1,245 pooled participants who were naive to Cabotegravir, and this is the only group this analysis looked at. And this is data which was presented at the EX conference in London in the end of October 2021, so not so long ago. And the analysis presented there concentrated on the 522 European participants of these 1,245. And you see the breakdown by country on the right-hand side. This slide summarizes the baseline characteristics of the European participants from the phase 3 program. And you can see on average, this was a 40-year-old population, but you can see there are also quite some younger and some older patients in there. If you look at the range, 20% were female, most of them were Caucasian, a little bit of Hispanic Latin ethnicity. The median BMI was 24, so that would be normal. And you can see that there are some baseline factors which have been associated with an increased risk of confirmed virological failure. And you see that indeed some of the individuals included had some of these risk factors which have been discussed as a potential increased risk for virological failure, including rilpivirine resistance-associated mutations, HIV-1 subtype A6A1. This is a subtype which you find quite commonly in patients from Russia, for example, or Eastern Europe, but to a much lesser extent in other Western European countries. And you can see there were also quite some patients included who had a very high BMI. Now, if you look at the overall response rate, so how many are remaining suppressed below 50 copies, you can see this is 95%. So I think this is excellent. Like in many other switch studies, a very high response rate. And if you look at those who have non-response, so a detectable viral load above 50 copies, this is 0.8%, which really tells you that the risk of virological failure overall is very low in this patient population. Indeed, there were only 3 individuals of the European participants from this phase 3 program who developed protocol-defined confirmed virological failure. And if you look at these individuals, you can see that one was a female from France, and she had an AG subtype and also NNRTI resistant associated mutations at baseline. The other two had none of these factors. If you look at the resistant associated mutations at failure, you can see that the one individual who had mutations at baseline also had them at failure, and one of the patients from France, one of the male patients who failed, also had the development of an integrase inhibitor related mutation. So the message here is that there is a very low number of patients who develop virological failure, but of those, some have risk factors present at baseline, some don't. So whatever risk factors have been identified or associated with increased risk, it does not necessarily preclude that you can still fail even if you don't have these risk factors at baseline. And you can also see that if you fail, there is at least some risk for mutations which can develop. And that is a little bit different because remember, if we give our second generation integrase inhibitors or we give a boosted PI, the risk of resistance development in patients who are naive and receiving this therapy is very, very low or even non-existent. So that is a difference. So there remains a very small, but there is at least a risk for potential virological failure with resistance development. Of note, this number is very small, it's less than 1%. And also note that these three individuals all resuppressed on alternative regimens. So it doesn't mean that if they fail, they're not able to be treated anymore. They can be suppressed with other regimens. Looking at the safety, obviously, if you inject, and remember, these are 2 injections with 3 milliliters each, so there is quite some volume you have to inject. Injection site reactions are probably the most common adverse event, and you can see that this is a little bit more during the initial injections. It looks as if there's people get used to this over time, and you can see that there's a little bit of pain associated with the injections. Nodule formulation is only present in 1% in duration, less than 1%. Very few have a grade 3 or higher event. Median duration of injection site reactions is 3 days. And the amount of individuals who withdraw because of injection site reactions or injection intolerability is very, very low, with only 2%. So although this happens quite frequently, it is tolerated very well and does not lead to treatment discontinuation. Now, one of these specific findings of questionnaires around treatment preference, and this is taken from treatment preference questionnaires within the Atlas and Flare study. They want to ask the question, for the past 44 weeks, you've received long-acting injectable HIV medication. How do you compare your experience in the long-acting injections with the oral medication you received prior to entering the study? And you can see that indeed 90% prefer the long-acting therapy. Now, I have to say, because we participated in all 3 studies, is that I really have to say that we hardly saw a study where people were so enthusiastic to join. So the motivation in some individuals is really high, and where sometimes you have a trial in treatment-naive patients where people are, not really seeing why they should join the trial. This was very different. People really lined up and actively asked for participating because there was really a group of individuals who really wanted to receive long-acting therapy. So you have a selection towards people who really want this therapy. So obviously then the questionnaire is also going to tend to show a very high treatment preference for the long-acting therapy. But I think of note is that if people want long-acting, they are very happy under this therapy. Now let me share with you some of the data from the long-term follow-up up to week 152 from the Atlas 2M study. So this was a study which looked at virologically suppressed patients. A lot came from the original Atlas study, which was Cabotegravir Rilpivirina long-acting every 4 weeks. And this study really was aiming at looking after the oral lead-in to compare the 4-weekly with the 8-weekly therapy. And you can see that there are different dosages used for the 4-weekly and the 8-weekly injections. Primary endpoint was plasma HIV RNA about 50 copies at week 48. Now, what we saw here at the CROI conference was, though, the prolonged outcome up to week 152. Now, the non-inferiority margin was defined at 4%, and you can see that in the intent to treat analysis, the overall proportion of people with a plasma HIV and RNA above 50 copies was within this 4% non-inferiority margin. So non-inferiority was reached and demonstrated. You can see that the virologic success, defined as less than 50 copies, was numerically comparable with 87.4% for the 8-weekly administration and 85.9% for the 4-weekly administration. But what you can also see is that in this analysis, that although non-inferiority was demonstrated, you can also see that both values to the side are above 0. So that suggests that there is superiority for the 4-week arm over the 8-week arm. And that becomes a little bit apparent when you look at the snapshot outcomes. So although the overall amount of patients achieving undetectability was very much comparable, you can see that there is a numeric difference in those who have an HIV RNA above 50 copies, which was 14 individuals in the 8-week arm versus 5 in the 4-week arm. And if you look at the discontinuation for lack of efficacy, it was 12 versus 4. So there seems to be a trend for somewhat more patients in the 8-week arm not responding virologically and being discontinued for lack of efficacy. Now, if you look at the confirmed virological failures, so protocol-defined confirmed virological failure through week 152, you can see that there were 13 participants who had confirmed virological failure, 11, 2%, were in the 8-week arm, and only 2, less than 1%, were in the 4-week arm. So that's where you see the difference. That explains why there's a sort of a difference between the 4 and the 8-week arm. Now, I think we would all agree amount of confirmed virological failures overall is very small, but it's still a little bit higher in the 8-week arm. Most of these failures occurred by week 48, so 10 of 13, and 6 of the 10 had more than 2 baseline factors, so either proviral rilpivirine resistant-associated mutations, the subtype A6A1, or a high BMI, which have been reported to be associated with increased risk of failure. So that is, but note that 40% did not have these 2 baseline factors. So I think the algorithm per se does not explain virological failure for everyone. Looking at the injection site reaction summary through week 152, because obviously the question is there an issue with injections after year 3? How is that going to be continued over time? But you can see that again, the amount of injection site reactions remains stable. There is no signal of more higher grade injection site reactions. And you can see that the amount of people withdrawing for injection-related reasons remains around 2%. So is very, very small. And that is really not, I think, a concern of this therapy. So what are the critical questions? Well, obviously, as a physician, you want to know what are the baseline factors which are associated with an increased risk for virological failure. Does BMI play a role or not? Is an oral lead-in always necessary? And what to do if an injection is missed or cannot be carried out as planned? So there was an analysis published in AIDS last year, which looked at various factors and performed a multivariable logistic regression analysis of confirmed virological failure through week 48. And as mentioned before, rilpivirine associated mutations at baseline had the highest impact on the risk for developing virological failure. You can see that the baseline subtype A6A1 also plays a role, somewhat smaller than the rilpivirine mutations, but still has a role. And then BMI is only very, very small here in this analysis, and only in the backward elimination model reached significance. Now, there was an interesting presentation at the IS conference in Berlin last year. This is from Charlotte Charpentier from Paris. She looked at the prevalence of these baseline risk factors for cabotegravir rilpivirine failure among treatment-naive patients. So she looked at patients from Paris in 3 different hospitals and sequenced reverse transcriptase and integrase and captured some other important findings, and then looked at how many of these baseline virological factors which have been associated with the risk of virological failure to CAB and rilpivirine exists. And she found in this French database, there were 183 sequences who were A6A1, and that is one risk factor. So that was not so rare. And she also found quite a number of sequences which were resistant to rilpivirine. So she said overall, 10% of the patients had one baseline virological risk factor for viral failure. But remember that in that analysis, you had to have two to obtain virological failure. So if you only had one, that was not associated with an increased risk. And only 0.4% had two baseline virological risk factors. So what she's saying is that you can only find a small group which really has a higher risk for virological failure. I think it does underline, though, that probably performing resistance testing at baseline in naive patients still remains important, because if you ever in the future want to switch to a long-acting therapy, it would be good to have that kind of information. Do you belong to the 0.4% or not? The question about the BMI has played a role, but if you look at this analysis where they looked at the pooled cabotegravir rilpivirine long-acting participants across the three phase 3 studies, Atlas FLAIR and Atlas 2M, and on the left-hand side, you see BMI less than 30 kilogram per square meter, separated by 8 weekly administration versus 4 weekly administration. And then in the above 30 kilograms, so the obese patient population, you can see that the amount of patients responding is very similar between the low and the high BMI group, 93 to 94% for the low BMI group, 92% for the high BMI group. 10 versus 11 participants had a viral load above 50 copies in the lower and higher BMI group, respectively. So not too much of a difference. And if you then looked at those who only had a high BMI as the only baseline factors, so did not have the A1, A6 subtype or rilpivirine-related mutations, then there was really no impact on the overall response rate. So BMI per se, just by itself alone, should not preclude use of this therapy. One of the other questions, obviously, do we always need an oral lead-in? This plays a role, obviously, in patients with a pill fatigue or with malabsorption, tolerability issues around tablets, where you would probably want to skip the oral lead-in. And the FLAIR extension study looked at exactly that. So there was a group which was directly transferred to the injection group, and then there was an oral lead-in group. And as you can see here, there was no difference in the number of adverse events leading to withdrawal or serious adverse events. So the safety profile was comparable, reassuring us that probably if you start right with injection, that also will be possible, although this is something which obviously has to make its way into the label, depending on which label you eventually will get in Mexico. Another issue is obviously around the point of management of missed injections. And that is something which is in clinic sort of relevant, because in the COVID pandemic, we obviously had patients who got caught somewhere during lockdown or were in quarantine and suddenly couldn't show up for the injection. So that is something which is relevant. But remember that you can always also do oral bridging. That can be done with the cabotegravir rilpivirine oral formulation. But we also had patients who then at least had their former oral medication they were coming from. We said, well, just continue then your oral medication. And then there are sort of patterns of how you perform. So if there's a longer interruption, then you will have to reinitiate with the 3 milliliters, one injection, then 1 month later, the second injection, then you can go back to the every 2-month injection dosing schedule. So there are ways of bridging in case more than 7 days have passed since a scheduled injection visit, which is something which can occur particularly in a COVID-19 pandemic. Now, I think if you ask German physicians, I would say there are some which sort of are very enthusiastic. They say, we don't really have too much issues, work very well, we're very enthusiastic. And then there are, I'm sure, also groups of physicians who are quite reluctant because they say, listen, we have to do the COVID vaccination, we have to build up PrEP clinics, and now on top, we have to start giving all these intramuscular injections, watch patients after the injection has been done, and they just perceive a lot of barriers to implementation. So there have been various studies in the US, but also in Europe, looking at perceived barriers to implementation among healthcare staff and how that changes over time. And this analysis in particular lists some of the various issues which were raised: patient ability to keep monthly appointment, patient transportation for monthly appointments. So this is from the US, where initially cabotegravir was only licensed for a 4-weekly administration. And you can see that at baseline, a lot of perception was that there were issues around patients keeping their appointment, the transportation, missed visits, staff resourcing, and so forth. But you can see that in green, the bars are much more reaching out to the right and capture quite a majority of healthcare staff. But then after 12 months, you can see that that has declined significantly, telling you that once the flow has been implemented, this works much better. So it does take a little bit of time for the healthcare staff to get used and the procedures, but once it runs. We had around 30 individuals who participated in the various trials we participated in, and all of them are now are seeing, because the studies have stopped, so they are now in their regular care of the outpatient clinic, and it has been integrated. It takes a little bit of time, but it is something which is implementable. So according to this study, at least the optimal implementation was achieved in 1 to 3 months, and barriers to implementation substantially decreased by month 12, except obviously for injection and soreness, which comes, I guess, naturally with intramuscular injections. And so I think the guidelines have moved ahead and are now all recommending, so all international guidelines, including the European AIDS Clinical Society, are recommending Cabotegravir as a switch option in virologically suppressed adults. And clearly, this is something which is gaining growing interest and use, at least in the European patient population. And the reason for that is obviously that patients want to have flexible treatment options for HIV care. I think for me, it would be 2 dominant groups. It's the one which is around stigma, the wish not to be daily reminded of HIV, and also not wanting to disclose my HIV status to somebody else, hiding the medication. That still remains a very strong motive. And then there's just simply people who want to enjoy life and not be reminded of HIV every day. And then clearly there is the group who simply has issues around swallowing oral medications over long periods of time. And I think if we believe that individual treatment choices are key for achieving long-term virological control, I think we should be happy that we get new modes of delivery, which allow us to offer our patients more flexible treatment options if they're needed. But I think current long-acting strategies come with a lower genetic barrier. The risk for virological failure is very low, but there are individuals who fail and develop resistance. That is different than what we see with the 2nd-generation integrase inhibitor in first-line therapy, where there also are some patients who don't adhere and fail virologically, but on average, we do not have resistance development. So I think we need to counterbalance this lower genetic barrier with the reasons for switching to LA therapy. But I think in the end, a rich armamentarium ensures that we can individualize treatment and obtain long-term success for all the individuals we treat. And with that, I say gracias. Thank you for listening. And this is a friendly hello from my bond group during COVID-19 times. Thank you.
Thank you very much, Dr. Jürgen, for your excellent presentation. Voy a empezar a hablar en español, doctor. Ahorita usted tiene la traducción. Estuvo súper interesante esta plática que ahorita nos acaba de compartir. Nosotros aquí en México, como el doctor Mata le comentaba al inicio, todavía no tenemos la oportunidad de trabajar con este medicamento en nuestros pacientes. Ahorita escuchando su plática, pues me surgen algunas preguntas o algunas cuestiones que tenemos en particular en México. Una de ellas es que ahora que nosotros estamos utilizando inhibidores de integrasa en forma masiva en muchos de nuestros pacientes, hemos tenido como problema el aumento de peso. Nuestros pacientes, al estar utilizando los ISTIs, cuando hemos hecho los cambios, dentro de los primeros 9 meses han tenido un aumento muy significativo de peso. Algunos han subido más hasta del 10% de su peso corporal que tenían previo al cambio. Entonces, esto que menciona acerca de que el índice de masa corporal no sería una contraindicación para poder utilizar este tratamiento, pues a nosotros nos beneficiaría porque sí tenemos a los pacientes con estos problemas de sobrepeso y también con el problema metabólico que nos ha hecho consecuente el aumento de peso. En este caso, en este panorama, ¿usted opinaría que a nosotros los pacientes candidatos pues serían pacientes suprimidos que no tuvieran ningún antecedente de haber tenido una falla, sobre todo con inhibidores no nucleósidos? ¿Y no importaría el problema metabólico?
Yeah, so I think what is important to say is that there really have been detailed studies on people with higher BMIs. And one of the issues is that, at least in the studies, it was recommended that you use a different needle length, right? So you're able to ensure that, the drug gets where it's supposed to. You have to use a larger needle for people with a high BMI, and that was not done correctly in the trial everywhere. So there was some issues with the needle use. But even though, despite not using the correct needle everywhere, there was still no impact of just BMI alone on the overall response rate. So that tells you that you're relatively safe. And they did very nice PK studies showing that the drug levels are very good. So I think that's very good. I think the whole story of weight gain is a very complicated one, because obviously every individual who has HIV when he starts therapy gains weight, because that's a return to health benefit phenomenon. And the question is there something beyond that which is associated with the drugs we're using? And you know that the African studies, the advanced trial, showed this very high increase of over 10%, and I think over like 11 kilogram after 2 years in patients who received dolutegravir and TAF in African women. But this is not what has been shown in other studies. And you can see that in these switch studies, the weight gain in people who were suppressed on a regimen, for example, in one of the studies, it was abacavir 3-TC dolutegravir, and the people who were then in the injection arm, the weight gain was not very different between the arms. So it's a little, I don't think that we can say that you're going to lose weight just because you're on an injectable. But obviously, many of the modern therapies include TAF, and an integrase inhibitor may be an issue. Obviously, there is more and more data suggesting that maybe TDF is associated with weight loss, and it's really not so much weight gain with TAF, but it's really more not having the weight loss, which we used to see with efavirenz, for example, and TDF. So that's still an ongoing point. But I would say that I wouldn't be worried if people have a high BMI to use injectable therapy. Obviously, you want to make sure that these individuals do not have resistance to prior NNRTI therapy.
Muchas gracias, doctor, por esta respuesta. Y también ahorita algo que me llamó la atención de lo que usted nos platica de la vida real de los pacientes que ustedes tienen, que hay muy pocos que caen en falla virológica. Una vez que ustedes encuentran que el paciente no ha estado suprimido, ¿cuál es su forma como dan el seguimiento o qué realizan ante una carga viral detectable?
Yeah, so that's a great question, because most of the individuals are undetectable, then you don't have to worry. But what are you going to do if you have someone who has 120 copies? So he's not below 50, but he's also not above 200. And because there is the risk of resistance development, are you more worried? And how long are you going to tolerate that? And obviously, I can tell you that in the trial, we had one individual who, then he had 120, then he had 80, but he was not always undetectable. And then you get nervous, right? Because you think, oh, this is eventually going to lead to virological failure. And that was not so easy, but the patient really wanted to be on the injectable. So I have to say that is something where you sort of, as a clinician, have to sort of see how things are. And I think one of the things we're worried about a little bit is that obviously in clinical trials, people are usually more adherent than in real life, because the study nurses, they come very often for frequent monitoring, and it's a more close setup, no? As in real life, where people then may not show up, and it's a different form of group, and I think that's something where you have to sort of develop a system to make sure that if people don't show up, for example, that they are called, or you reach out to say, well, you missed your injection, the next injection has to come, and how we're going to deal with that. And I would say, if I have someone who's constantly blipping and not undetectable, I would probably feel more comfortable putting him on or her on a different regimen, just because our experience is limited in people who have ongoing low level of viremia, and is that associated with a higher risk for virological failure? I don't think we know. I can say that from the patients we had one individual that was a problem, but that was the only one. So it's not really a very common finding, but it is something where, but that for me was the same in the old days when someone was on efavirenz and he was, after years still having 200 copies, I was more nervous than if he would be on a boosted PI or on dolutegravir, right?
Sí, claro. Sí, eso es muy, muy importante. Y pues bueno, hay una pregunta aquí en el chat que dice: felicidades, doctor, por su ponencia. Me gustaría saber si existe evidencia sobre qué haríamos en pacientes suprimidos virológicamente posterior a realizar switch a cabotegravir rilpivirina de larga acción, si se diagnostica tuberculosis pulmonar y se debe iniciar tratamiento antituberculoso.
Yeah, that's a great point, because that's one of the few issues where there are drug interactions with the TB medication, and I haven't seen that, quite frankly. I know there are drug interactions, and we'll have to look that up, but it's not, in our setting, not very common, because obviously people who are suppressed and switch are usually stable patients, and the probability of developing a tuberculosis is much lower than people who are initially diagnosed, right, where you then start therapy. But since cabotegravir and rilpivirine are only used in the setting of suppressed patients, they sort of already have passed this problematic time point of interaction. But TB medication is one of the few things where you have to look, and I can't tell you out of my head how it works with rifampicin, but there is an issue.
Sí, es algo importante de reconocer. Y pues bueno, también aquí en México, doctor, pues sí tenemos ciertas cosas singulares. Nuestros pacientes generalmente los diagnosticamos en etapas tardías, ya en SIDA. Entonces presentan CD4 muy bajos y a veces su reconstitución inmune es lenta. Entonces nos ha pasado pacientes que, a pesar de que ya están indetectables, más adelante se desenmascara una tuberculosis. Por eso es la pregunta que se le realizó. Le voy a dar la palabra al doctor José Antonio Mata, que tiene la mano levantada. Adelante, doctor.
Thank you, Violeta. Thank you, Dr. Rockstrom, for
Yeah.
your very interesting topic. I have two questions. The first one is, do you think it's a short time, 2 months, for this kind of drug? I mean, for example, in my clinic, when I have a patient under control or under viral control, I check my patient 6 months. Then if I have to see patient each 2 months, like it will be complicated for me. I don't know how are you doing in Germany to see patient more frequently, or is just a nurse that put the injection, or how are you doing that?
Yeah, I think that's a great question because it's a real life question. And I can tell you that in Germany, it's a little bit different because most patients are seen every 3 months. And that has a lot to do with the reimbursement system. So if you're in private care, you have a private practice and see your patients, whether they have public health insurance or privately insured, then you get reimbursed for measuring CD4 count and viral load every 3 months. And that's why the Germans stick to these 3 months, because that's their income. No? But quite frankly, if you ask me, do you need to see your patients every 3 months? No, because, right? Because if you're in year 5 undetectable, why do you need to come every 3 months? So in a university clinic where I work, where your salary is the same, whatever you do, you're more inclined to see patients in longer time intervals, whereas in private practice, people are seen in shorter time intervals. Obviously, in England, during the lockdown, people have moved to see them once a year. I think for me, once a year is not enough because of the high rate of STIs, the complex comorbidities we're taking care of. So I'm not a big fan of once a year. I think that's not enough. But I would agree that if you see them every 4 months, every 6 months, is completely sufficient. And you're right, if you have a very high caseload and suddenly all these patients show up every 2 months, that increases whatever you do tremendously. And I think that's one of the reasons why a lot of people were a little nervous. Now, in UK, nurses do the injections. In my setting, in my university setting, I have to do it myself. So there is a natural reluctance because you feel like, wow. But there are private practices which say we have enough staff, it's no problem at all. So that's why I try to say that in Germany, it's very split. There's some centers which say this works super and we're really thrilled and the patients love it. And then there are some centers more like some of the university centers like ourselves, where we say like, oh, can be a challenge. But, I think the point is, it's not that like we have 1,200 patients, it's not that all 1,200 patients say, yes, we want injectables now. But for those, 30, 40, 50 who say, I just have difficulty with the tablets, or this guy who's like really waiting for a different way because he says, I'm always having issues with my stomach. For him, it's a complete relief. So I think what we can do is for those, I would say 10, 15% who are really ready for something different, this is a great solution. I would agree that it's nothing where you want to also it's more expensive. So it's not like you're going to full-heartedly say, I'm going to switch everyone. I think there are a lot of patients who say, you know what, if this would be a 6-monthly injection, you got me right convinced. But if I have to come every 2 months, and I tell you, the biggest challenge in a university clinic is to find a parking lot. There is no parking. So, so there are many logistical issues, and coming every 2 weeks is just too much. No? But if you, it's always interesting when your colleagues go on vacation and you cover their patients, and so because they know I do all these studies, they say, well, Mrs. Dr. So-and-so is not there, so let me ask you a question I've been dealing with. It's like, when are the injectables coming? And I said, well, but you have a tablet, 1 tablet per day. That's so easy to swallow. Why would you want to come every 2 months to the clinic? He says, oh, my wife doesn't know that I have HIV and I'm always hiding my tablets and I'm so afraid she finds out. And if there's an injectable, please, I want to do that right away. So, the motives are very different. And I think, you sort of have to give room to listen what there is. But I think for some people, it's like, the new thing, the new kid on the block. So, but you're right. There have been quite some, because you have to think of like, how do you get the medication? It has to be cool. Who's going to bring the medication? Where do you store the medication? Do you need more fridge space? If you give the injection, are you going to monitor your patient after that? The room is going to be blocked for 20 minutes. How you deal with all these things. So there are logistical questions you have to ask yourself. Very right. And let me just add one. Yeah. I just want to add one thing, just because I looked it up so rifampicin is contraindicated with long-acting cabotegravir. So
yeah. And two short questions. The first one is,
Gracias.
do you recommend the oral let-in before to start injections? Because some trials present that maybe to start with injection is enough. Do you recommend to start with oral let-in or direct to the
So I would say, if the patient is willing to start with an oral lead-in, I think the oral lead-in for me personally offers the advantage that I can see, does he tolerate the 2 drugs before I give an injection? It's in the body for the next 8 weeks. No, the only thing is that there's some patients who can't swallow or have where you really want to give an injectable because it's an issue. Then I think it would be nice to start right away with injectable, and it makes things a little bit more simple, because otherwise you say, well, first you take the tablets and this is different than your regimen before, explain all that, and then at day 28, it gets very complex, right? So if you could say, we're switching right away to injection 1, injection 2, and then every 8 weeks is easier in sort of a simplified explanation process. So I think for some people it's easier that way. So it depends a little bit on also how afraid are the individuals of given side effects. What have they been on before? Are they familiar with integrase as a class? Things like that.
Okay. And finally, Dr. Rockstrom, maybe you talk a little bit about it. Are you worried about the archives mutations about NNRTIs? Because worldwide are very common. For example, in Mexico are more than 10%. Some NNRTI mutations, and I don't know if you are worried about it when you start rilpivirine like long-acting.
Yeah, so if I understand correctly, it is specifically rilpivirine associated mutations. Now the beauty of rilpivirine is that if for example K103N is your dominant mutation, then you would still expect rilpivirine to be active. So I think the frequency of rilpivirine associated mutations as a baseline mutation for those who have not been exposed to rilpivirine before is relatively low. That was the interesting part of the French presentation. They didn't find a lot of rilpivirine mutations in combination with other risk factors. And remember, there were 2 factors you need to have for failing. But what worries me, though, is that in the end, there are patients who fail regardless whether they have baseline risk factors or not, and still have measurable drug exposure. So in general, I think we have to accept, and if you look at the lenacapavir data, patients who fail also develop resistance. So somehow these long-actings come with a risk of resistance. It's very low, but there is a risk. And that's why I always say the value of the long-acting has to be because the patient says, my life quality is double as high because I don't, I can deal better with my HIV stigma. Okay, then you're doing that because you actively want to get rid of that problem. But if someone says, I feel great under my therapy, and I just want to try something else for fun, then I would say, well, listen, that comes with the risk of potential virological failure and resistance development, which other regimens do not have. So you need to counterbalance, I think, these things. That's at least what I think.
Thank you so much, Dr. Rockstrom.
Y doctor, una última duda que ahorita me surgió con lo que estuvieron platicando. Entonces, ¿sería imprescindible que tengamos que realizar un genotipo previo para poder utilizar estos fármacos de acción prolongada?
Well, I would say you need 2 factors. So if you haven't, because you know how reality is. People walk into your clinic, they don't know whether they had a resistance test or not. That's how it is. Then I would still say that based on the French data, the risk for biological failure is not higher than 0.4%. It's very low. But that's why I think in general, it's probably better if we still stick on doing a genotypic resistance test, because then we would at least know whether there was a rilpivirine mutation or not. And that's why I think it is still better if you have that information. But I think we have to be realistic patients have a normal life expectancy. You're going to see people 20 years into therapy who walk in and said, I had a green pill, a red pill, and blue pill, and I have no freaking idea what my genotype was, and the doctor is not reachable. And, you know, that's how it is. No? So, and then that's why I think, though, that there always has to be, you know, if you do it, and you go for a risk, even if it's very small, there has to be a reason why you do it. And if you say, well, you know, I can't swallow tablets any longer, I'm really sorry, I'd rather take no medicine at all than swallow tablets. Well, then you do it because you have an alternative which, you know, allows treatment, and then you just live with that 0.3% risk.
Muchas gracias, doctor. Pues bueno, el tiempo se nos ha acabado. Y pues creo que tuvimos una discusión muy enriquecedora. Le agradezco mucho el haber presentado con nosotros y pues bueno, seguir invitándolo para poder contar con usted en posteriores charlas, doctor.
Yeah,
Le
and
agradezco.
hopefully in Mexico so we can have margaritas.
Ah, claro que sí, doctor, y con todo gusto se las invitaremos nosotros.
Okay. All right.
Muchas gracias, hasta luego. Muchas gracias a todos los alumnos que se comentaron.
Goodbye. Hasta luego. Thank you.
Hasta luego.